We are live, please. We are live.
Good evening, everyone. Welcome to the another episode of AIS ARC webinar. Today's topic is what bugging us. It's basically on the infective keratitis, and the chairperson for the today webinar is Dr. Samar Basak sir, Dr. Namrata Sharma ma'am, Dr. Radhika Tandon ma'am, Dr. Rajesh Sinha sir, Dr. Amrish Darak sir, and Dr. Bhupesh Bagga sir. Moderate the session from questions meanwhile after the each talk. So I will hand over the mic to Aditi to start the procedure. Our chairpersons will join shortly. Dr. Aditi, please.
Thank you so much, sir. So we will start our session with none other than Mamta ma'am's talk. So today we have gathered all the excellent cornea consultants who are working on infectious keratitis, and we are trying to decode all the mysterious and mischievous cases of infectious keratitis. So we all the Mamta ma'am, she's working as assistant professor of ophthalmology in AIMS Rajkot. And ma'am, over to you for your presentation.
Thank you, Aditi. Thank you so much. Good evening, everyone. And I hope my slides are visible. Okay, let me just put it there. Is my slide visible? Am I audible?
Yes, yes.
Okay, thank you, Dr. Deepak, and thank you to the
Yes,
entire ARC team for this wonderful opportunity. I will be talking about some of the fundamental and essential procedures that we need to master if we are dealing a case of infective keratitis. I will start with ocular surface staining, and if we talk about a normal healthy ocular surface, it does not get stained because of its hydrophobic nature. And that is mainly due to phospholipid, galactine, mucin, etc. But once the epithelium is breached or it is compromised, it starts taking stain. And as the dye goes down across the thickness of cornea, it tends to spread because of the gap junction between cells. So if we are examining a case of infective keratitis, when we want to focus on the shape or margin of lesion, it's a good practice always to examine these cases immediately after staining. Otherwise, there is a chance that the entire lesion will fuzz out or it will not appear discrete as it is. Mainly, we use one of these dyes, fluorescent. If you want to see a corneal pathology, then against the dark background of iris, fluorescent is the dye is the obvious choice. For conjunctival pathology, against the white background of sclera, LG, or lissamine green or rose bengal, any of these two can be used. For conjunctival also, if you are using fluorescent dye, then it's better to use yellow filter. And if you are using the cobalt blue filter, then start with the maximum illumination with fluorescent dye. But for other two, that is LG and RB, start with lower illumination and then gradually titrate it till you get the maximum contrast. That is how we can see the lesion more clearly. There is something called quenching phenomenon. Ideally, as we increase the amount of dye or the concentration of dye, this should appear more fluorescent. But this is possible only up to certain extent. Beyond that, it gets dark. So if we know that there are there is a lesion over the ocular surface and we do not see it clearly, not as fluorescent as it should be, then it's a good practice to put a little bit of diluting drop over the surface. Once the dye concentration goes down, the fluorescent property will appear. That is something we should always keep in mind. This is the ideal diluent solution is normal saline, but moxifloxacin is something what we all use. With fluorescent stain, it is always the excess dye which is the problem. So my practice is either to gently shake it off before I put it over the ocular surface or put the diluting drop a little over the stained area. So by the time it comes towards the dye portion, it goes off a little. And then with RB and LG, it's always the lesser amount of dye, which is a problem. So I allow it to soak it for like 15 or 20 seconds, and then only I use it. Or at times I use 2 strips together also, depending on the requirement. So then there is a situation when we need to differentiate between positive stain and pooling of the dye. A very simple thing is to do is to ask the patient to blink multiple times. The dye, it gets displaced, or the lesion actually, it appears to be changing shape. So that gives a clue in addition to other tests like, using the bud or using a sponge at that place. A very good article for postgraduate level or for any of us would be is by Dr. S.K. Rosser and Srinivasan Rosser, and it's published in IGO. My recommendation would be to go through this article if we want to know anything about ocular surface staining. Next, I'm going to talk about corneal scraping, and mainly I will be dealing with diagnostic and therapeutic scraping. I will definitely scrape my ulcer if I have a moderate or severe ulcer. Severe ulcer does not always mean this means completely punched out ulcer. Even in those cases, we can use sponge or a wet bud for taking the microbiological specimen. Then I will definitely scrape an ulcer which is not responding to the empirical treatment, or when we have atypical presentation of ulcer, or we have a post-corneal surgery corneal ulcer, and when there is a history of trauma, because many a times it happens that there is a foreign body over the ocular surface and over which the exudates keeps on collecting. So if we do a scraping, then we can remove the foreign body also, and that will help in the healing process. I will definitely scrape my ulcer when I'm dealing with a one-eyed patient. The requirements are very basic, minimal, like any local anesthetic or surface anesthetic. Wire speculum use is optional. My preference is always 15 number surgical blade, but depending, one can use needle or spatula if it is available. For diagnostic purpose, glass slides, cover slip, culture plate, but we need to have this facility of managing corneal perforation, at least tissue adhesives should be there. The idea is to scrape both the base and the edge of ulcer, and it should be unidirectional. It cannot be like to and fro in both the direction. That is how it is done. And if I'm doing it for the diagnostic purpose, then I prefer to put it directly over the culture plate. And for gram staining also, I directly put it over the slide, and I try to make a thin layer of it, as thin as possible. So that is how we do it for the diagnostic purpose. This was a case of ocular surface foreign body along with ulcer, and it was clinically fungal corneal ulcer. We started empirically with the antifungal medication, and the ulcer responded very well. But 2-3 weeks down the line, the ulcer just stopped responding. So we did a therapeutic scraping at this stage, and within 2 weeks, the ulcer got completely healed. So multiple scraping, depending on requirement, is the way to go for it. So meticulous scraping is the key to successful treatment. It has to be unidirectional. Both the base and edge of the ulcer needs to be scraped, and repeated scraping may be required both for the diagnostic and therapeutic purpose. Next is the use of tissue adhesive in perforated corneal ulcers. They can be used as a primary sealant, or they can be used along with other biological tissues. What is important here to consider is the size of perforation and what is the basic etiology there. We can use synthetic glue like cyanoacrylate, or we can use biological glue like fibrin glue. Cyanoacrylate is a very strong adhesive. It polymerizes rapidly over the corneal surface, and the peak bonding strength is seen after 2 minutes. It stops stromal melting, and it has got bacteriostatic property against the gram-positive bacteria. It is best suited for corneal perforation, which are less than 3 mm in diameter, which are concave in profile, because it has this tendency to form a mass over the surface, a mound over the surface, and which is located away from the limbus, because over the surface of conjunctiva, the adhesion is not very strong, and it causes intense inflammation over the ocular surface. Clinical application, I prefer direct application with needle only when there is a large gutter, like in cases of PUK and all. Otherwise, mainly we go for different applicators like Merocell sponge or glue and patch technique. This video is basically to highlight what we should not do. Like this was a case of leaking corneal ulcer, and the idea is to remove the overlying exudate and any dead tissue and debris from the surface. But we should not do it with this. With so much cotton threads lying around, it's going to get adhered over the surface. Similarly, we use normally the sponge for putting the glue over the surface. But many a times when that is not available, what we do, we just remove this cotton part, and then we use this portion for putting the glue over there. So even if the sponge is not there, better to cut this cotton part completely and then use it for the glue application. That would be the better practice. Then put the minimal amount which is required. Just wait for a few seconds to get it polymerized, and repeat application is required only when it is actually needed. A large mass is not actually desirable here. And at the end of it, just put a bandage contact lens. This video is not mine. This is from an online source. This is the patch technique. We use the sterile drip, and with the help of a dermat refine, or even we can hand fashion it, we make sterile disc like this. Then we take any of the ophthalmic ointment. With the help of this, we are going to attach this disc that we have fashioned. And then we are going to dip it in the corneal glue, the tissue glue. And then we will be putting it over the corneal surface as we did it earlier, like this. This is another case, again, something interesting which happened here. As I said, in these cases where we have like deep gutter, I prefer using direct needle application. So as soon as the dye is coming out, we can see it's getting polymerized. It's not allowing even few seconds, 2-3 seconds. It's just getting polymerized. The glue which was there inside the syringe was complete liquid, but over the surface, it was getting polymerized immediately. Although the post-op result was this patient was, I mean, nothing different from any other case. But when we tried to, find out the reason for this, we saw that one of the probable reason, I would say, the expiry date which was written over the inside pocket was different from what was there over the outside pack. So this was kind of learning experience for us. So and then there are certain special clinical situations where we need to pay special attention. Like if there is a free flow aqueous through the corneal perforation, then it's important to put a temporary tamponade. Otherwise, the glue is not going to stay there. If the iris tissue is plugging the perforation and the AC is collapsed, it's important to reform the AC with the help of viscoelastic or air bubble. And despite that, if the iris is trying to, iris has got a very strong memory, it tries to come back. So if it is happening, then put a sterile plastic drip, put the glue over it. If required, put another layer of sterile drip, that is Duas technique, and on top of it, put BCL. And if we have nothing in our hands other than cyanoacrylate glue, and if we have to use it for a perforation larger than 3 mm, then put a mesh of 10-0 nylon suture and then put the glue over it. That is how we do it. When to remove the glue? Usually we wait for 6 to 8 weeks for complete epithelialization of the underlying surface. But an idea we can get, just by gently nudging the margin of contact lens. If the glue moves along with the contact lens, that means the underlying epithelialization is already done and we can safely remove it. Fibrin glue, mainly we have from 2 companies. And if we talk about comparative analysis between these two, then for defects up to 2 mm, fibrin glue is as good as or as effective as cyanoacrylate glue, but between 2 to 3 mm, if I have to choose, I will go for cyanoacrylate glue. But the advantage with fibrin glue, it can be used along with any other biological tissue like amniotic membrane graft, and this can be used for smaller perforation like 2 mm, 1.5 mm, and when the ocular surface is compromised, like in cases of severe dry eye or rheumatoid arthritis patient, when we want to use that nutrient property of amniotic membrane. Along with Tennant's patch graft, it's always better to put sutures also in these cases. Tennant's patch graft advantage is autologous tissue, minimal reaction, and it is definitely cost effective. This is a very old surgical video again. This was a case of corneal ulcer which healed with fistula formation. We just started with one of the iris depositor by a blunt dissection. We removed this pseudoterigium kind mass and we took a bit of Tennant's, fashioned it and put it over the, fix it there in the fistula. And then we put multi-layered amniotic membrane graft, covered this entire area also with amniotic membrane. And finally, this is the post-operative picture. This held really well. So if I have to summarize uses of tissue glue in perforated corneal ulcers, if it is less than 2 or between 2 to 3 mm, tissue adhesive can be used as a primary sealant, or they can be used with AMG or Tennant's along with suture as and when needed. For perforation larger than 3 mm, it's always better to use sutures along with tissue adhesive, and that can be used with any of the biological tissue like Tennant's or corneal patch graft. Okay, with this, I'm going to conclude. Thank you so much.
Thank you, Dr. Mamta, for the wonderful talk. Now,
Thank you, Dr.
our
Deepak.
president, Dr. Samar Basak sir, joined. He is well-known figure in the cornea and, in fact, the authority in the cornea. Sir, first your small welcome address, then comments on Dr. Mamta's talk. Sir, you are muted. Sir, kindly unmute yourself.
Thank you very much, Deepak, and this is wonderful. I promised you that I will be joining. I have joined around 10 minutes late, but I heard part of Mamta's lecture, and it is wonderful whatever she told about glue and the other substitute along with glue. And in fact, uh, uh, there are now 3 glues available in India, not 2. One is Relisil, one is Tisil glue. The Tisil glue, the cost is so prohibitive that you cannot sometimes afford for the patient, particularly single patient. It doesn't make sense. That way, Relisil, little bit, many people do not like it. And another one is Fibrintech. This is a new glue from Chandigarh that manufactured in actually Thailand, in Bangkok. Fibrintech, we are using Fibrintech and Relisil recently because Tisil sometimes we keep
Available.
it fully slate where it is mandatory, but Fibrintech is in between. What I will say that it is better than Relisil, little lower, but you can do well. The cost is also just little more than your Relisil. So it is that way it is working well. And another experience I can share about the glue, I had an experience couple of years back with that perforation due to trauma. I mean, it is a stiletto-shaped scar. Then VR surgery, then that scar opened and the eye was filled with silicone oil, unicameral eye. And gluing up a silicone oil filled eye unicameral, it is so tough. I mean, that day I realized that silicone oil is so slippery, so slippery. So after a long struggle, we actually able to do that glue. It is a tri-radiate, so small perforation, but ultimately the patient did well. So silicone oil filled eye. Otherwise, your thing is very good. So amniotic membrane 10-on patch graft is nowadays so popular and it saves our eyes. A lot of patient actually you don't need anything actually. In fact, you can also use the other thing like little bit like say it is 4 mm perforation. Then I call it that it is tissue plus glue. Tissue means here corneal tissue. So we have 3 mm punch, we have 2 mm punch. We can take those punches and we can take a little bit of cylindrical corneal tissue of 2 or 3 mm diameter. We just plug it and then you can put glue or you can put 4 sutures in 4 corners if it is little like 4 mm and then apply any kind of glue, whatever available in your hand, cyanoacrylate or fibrin glue. That also works so wonderful, and that also to some extent more biological than your 10-on patch graft. So there's I call it tissue plus glue plus BCL. So tissue here, I mean that corneal tissue, and then you can harvest those cornea little from your sclerocorneal rim, which is preserved in your eye bank. After using for PK or any other procedure, you have those in plenty in most of the corneal surgeons set. So these are few areas. So otherwise, excellent. Carry on.
Thank you so much, sir. Thank you for this golden words of wisdom, sir. Thank you.
Thank you so much, sir, for joining us. So we'll move on to the next talk by Dr. Pranita Sahai. She is working as Assistant Professor at RPC, AIMS, New Delhi in cornea, cataract and refractive services. Over to you, Pranita.
Thank you, Dr. Aditi, for that kind introduction. And at the outset, I would like to thank AIOS ARC team, Dr. Prashant Bhavankule sir and Dr. Deepak Mishra sir for giving me this opportunity. And I'm fortunate that I'm presenting in front of Dr. Basak sir. So with that, I'll move on. So the topic for my presentation is fungal keratitis, stiff between the protocols and the outliers. So fungal keratitis, they come in different clinical appearances. They have different clinical appearances, and it is important to understand this entity because it is one of the most common infective keratitis, especially in our subgroup of patients because it is more common in the tropical and subtropical region. Now, there are multiple antifungal drugs that are available, but majority of them have a poor ocular penetration. So which one to use, which one to start, and when to switch there are a lot of doubts and questions when you're dealing with these patients. Also, fungal culture sensitivity is not routinely available, and even if it is available, it's not routinely performed. And there's no comprehensive treatment protocol for general ophthalmologist for these for fungal keratitis. So that leads to a lot of dilemmas when you're treating these patients. The various options when you manage these patients include topical and systemic antifungals, targeted therapy, PAC-CXL, and when nothing works, therapeutic penetrating keratoplasty is the last resort. Among topical antifungal, various drugs are available, but the most commonly ones that we use are amphotericin B, natamycin, and voriconazole topically, and systemically ketoconazole and voriconazole. Among the topical antifungal drugs, natamycin is the only US FDA approved drug. However, the penetration is often poor and it comes in a suspension formulation. Also, we all know that this works well for fusarium. However, for aspergillus and candida cases, voriconazole works well. However, its used in fungal keratitis is as of now off-label. Amphotericin B again works well for candida and itraconazole for candida and aspergillus and has poor response for fusarium. So coming to one of the first landmark and one of the largest studies done in fungal keratitis, and fortunately which was conducted in our country itself, was the mycotic ulcer treatment trial 1. It was a multicentric trial study in which India was a major part. And in this, topical natamycin was compared with voriconazole, and it showed that the natamycin performed better with less requirement for TPK, less perforation rate, and better BCVA in patients of fungal keratitis. So let's have a deeper look into this study. They randomized 323 selected patients into two groups. However, one of the major concerns with the inclusion of the patient was in India, the patient recruitment was predominantly from South India, and the ulcers that were recruited was not on the basis of severity. It was a generalized recruitment of fungal keratitis. So we cannot say this study could not assess whether this drug comparison applies to mild, moderate, or severe. It was a general assessment that was done for all cases of fungal ulcer. Also, combination therapy was not tried in this study. This is how the baseline characteristics looks like. Both the groups were equally matched in terms of all parameters. However, one of the major concern here is that fusarium was the predominant species in this study, while overall in India as well as in North India, if we look at, the spectrum of mycotic keratitis is quite different. For our cases, the rate of aspergillus keratitis is slightly higher or at least almost equivalent to that of fusarium keratitis. So how much we can directly apply the results of mud to our patients is something has always remained a question, because the sensitivity of aspergillus and fusarium is different. Now, in the multiple logistic regression analysis, which was done in this study, they used visual acuity as one of their main outcome measure, and in which they said that there was a significant difference in which natamycin performed better compared to voriconazole. However, when we are looking at infective keratitis, our primary outcome measure is usually the healing rate and the complication rate and requirement for TPK. Vision is always our secondary outcome measure. Now, on the basis of looking at the adverse events, we saw again the study said that the corneal perforation and TPKs were higher compared to voriconazole. However, when we look at the statistical values, the rate of corneal perforation did not show any significant difference between the two, but the TPK rate was definitely different between the two, being higher in the voriconazole group. Now, another important catch here is that the location of ulcer, whether peripheral or central, how many were deep, how many superficial, have not been used in the analysis per se, which can make a major difference when we are assessing TPKs and corneal perforations also. So that needs to be taken into account because that can affect the results. Now, the second landmark trial that has been done in the field of fungal keratitis is the mycotic ulcer treatment trial 2, which looked at a very important aspect, that is the use of oral antifungal in fungal keratitis. So in this, the two groups were one having both combination of topical natamycin and voriconazole, and in the second group there was an addition of oral voriconazole. So these two groups were compared, that is oral voriconazole versus placebo, in addition to combination of natamycin and voriconazole. The dose of voriconazole that was given was 400 milligram BD on day 1 as a loading dose, and then 200 milligram BD for a total of 3 weeks. So what this study concluded was, the major conclusion was that there was no added benefit with oral voriconazole in this study. So looking at the details, there were 240 patients in this study that were randomized. However, if we look at the baseline characteristics here, unlike the baseline characteristics which gave in MUT1, p-values were not given with. So we are not sure whether the baseline characteristics between the two groups were equally matched or not. So the depth of ulcer, if we look at the numbers that are given here, the severity of the ulcers were, the ulcers that went into the voriconazole were more severe, were more deep compared to the one in the placebo group. The p-values have not been given in the study, but we are not sure whether this difference is statistically significant or not. Now, looking at their primary outcome here was rate of corneal perforation and need for TPK, and the secondary outcome were vision and other characteristics. So looking at the results, they said that adverse outcome, they said visual disturbances is something that was higher in the voriconazole group. However, the number of patients were only 5 who faced visual disturbances among 119 cases. Also, mild elevation of the liver function was noted in the voriconazole group. Again, majority of the patients in this study was also fusarium, and aspergillus was less than 50% of the cases. And on the regression analysis showed that the baseline enrollment infiltrate was one of the major risk factor that determined the risk of corneal perforation and need for TPK. So there are a lot of dilemmas when we look at the results of MUT1 and MUT2, that whether should I begin with only one drug, natamycin, when to add voriconazole, whether adding voriconazole has no role, then what to do when natamycin is not working, because oral antifungal, oral voriconazole has also been ruled out by MUT2, and when to give intrastromal and intracameral injection, and when is it indicated in my patient. So this is what all was assessed in the TST protocol. So in TST protocol, what we looked at was a comprehensive protocol wherein the cumulative effect of more than one antifungal drug, along with multiple routes of targeting being intrastromal injections as well, was assessed, and to devise a comprehensive treatment guide for general ophthalmologists when facing with patients of fungal keratitis. This was published in Cornea in 2019. This is how the protocol looks like. Any patient of fungal keratitis that presents is started with only topical natamycin. Only if the ulcer size is more than 5 millimeter or more than 50% depth, that is when systemic antifungals are added. And if in 7 to 10 days there is good response, then only natamycin is continued. However, if there is poor response at 1 week, topical voriconazole can be added. And again, for 1 week, a response is looked at. If there is good response to the combination therapy, that is continued till there is clinical resolution. If at 1 week there is poor response to the combination therapy, intrastromal or intracameral injections can be given in these patients. And if at maximum 3 to 4 injections can be repeated at 72 hours. And if there is no response to that also, therapeutic keratoplasty is the last response. And in the protocol of treatment, anytime if there is severe corneal thinning or perforation or impending perforation, therapeutic keratoplasty was done. So 223 cases that met the exclusion criteria were treated in this, recruited in this study. And the overall success rate of the TST protocol was 79.8%, which is equivalent to majority of the studies published for fungal keratitis, wherein the average success rate is around 80%. And the rate of corneal perforation was 6.7 and non-healing corneal ulcers were 13.2. Overall TPK rate was 20%. And hence what we hypothesized was that the early use of combination therapy and use of targeted therapy can result in less complication rate and better healing in these patients. This is a picture how a fungal keratitis, if treated in time, can heal well with minimal scarring. So Targeted therapy can be either intracameral injection or intrastromal. Intracameral these days is not practiced very commonly because a lot of studies have shown that the risk of intraocular inflammation post intracameral injection is high. However, voriconazole, amphotericin B, natamycin both have been tried. All three of this has been tried as intracameral injection. Next, what is more commonly practiced as a targeted therapy is the intrastromal injection, which is practiced in cases of deep and recalcitrant keratitis. And in this, with the help of a 1 ml tuberculin syringe and a 30 gauge needle, a barrage kind of a corneal hydration is done all around the ulcer. It is important that the bevel is up and you are at least 1.1 to 1.5 millimeter away from the ulcer and infiltrate edge so that you do not cause secondary seeds. And when you inject, you see this white hydration that occurs at the edge of the at the site of injection, and you give around 6 to 8 injections all around the ulcer to create a barrage kind of a thing wherein you're creating a depot of high concentration drug around the ulcer. So voriconazole, amphotericin B, and natamycin all have been tried. However, voriconazole is the one that is most commonly used, and this can be repeated at 72 hours intervals. Up to 3 injections has been described in literature. Now, various studies have reported that with the intracameral injection of amphotericin B, the intraocular inflammation worsens, and hence, because of that, a lot of surgeons have now shifted only to intracameral or intrastromal voriconazole injection, and recently, natasol is something that has also been tried as an intrastromal injection. So, but TST and any of the treatment algorithm cannot be a one-stop solution to all the cases because every case is different, especially candida keratitis. They respond well to amphotericin B is known to everyone. Pediatric cases where you need to treat them more aggressively, graft infections, one-eyed patients, which needs to be dealt differently because every case is different. So there is something known as recalcitrant fungal keratitis as well. When a fungal keratitis that is not responding to treatment for at least 2 weeks, that is when we label as recalcitrant. And all these new drugs, that is posaconazole, caspofungin, have been tried, and nanoparticle for sustained drug delivery have been tried, and PAC-CXL and Rose Bengal-based PDT have been tried. And also topical natasol is something that has been recently published. It's a water-soluble formulation of natamycin 1%, which does not precipitate and is supposed to have a good intraocular penetration and has a better patient compliance. However, there is only single study published on this, and more studies are needed before we can validate the same. Topical caspofungin has been tried in cases with a recalcitrant infection. Isolated case reports show good result. But something that we should not forget is povidone iodine or betadine cautery and corneal debridement, which is a must in all cases of fungal keratitis, and that works wonders. So drugs other than drugs, debridement and betadine cautery is something that you must do at every visit when you're treating these patients. And PAC-CXL and PDT-based cross-linking phototherapy, fancy things have been described, but of limited use as of now in the current management protocols for fungal keratitis. So with that, I'll conclude. And thank you for your kind attention.
Thank you so much, Dr. Pranita, for the excellent presentation. So we are now open for discussion with our esteemed panel.
I have a comment over here. Dr. Pranita, if you are dealing with a case of recalcitrant keratitis and like the normal antifungal, the routinely available one, it's not responding to that, and you're planning to go for caspofungin or any other medication, echinocandins, how do you decide about it? Which one to go for next?
So based on availability, first is availability of the drug is one of the major concern. These drugs are not routinely available. We have tried caspofungin in a few cases, but it doesn't work in all cases. It has shown response in few cases, but doesn't work. And therapeutic keratoplasty is what majorly is done for recalcitrant fungal keratitis as of now. So these are all experimental drugs. You can try them, but therapeutic keratoplasty is what you have to resort to in majority of these cases.
And what is your experience with the TST protocol, especially in severe keratitis, like grade 3 ulcers and other, how it has been?
See, if you start with the grade, if your ulcer size is more than 5 millimeter and more than 2/3 depth, In this protocol says that you start in a graded fashion with natamycin and then go on to voriconazole, but a lot of time we tend to start with the combination therapy at the first go itself when you're seeing these large ulcers. But with this study, it was seen that the response with the TST or a stage-wise treatment also works well, because a lot of patients respond just to natamycin as well. But I think it's an individual choice when depends upon the profile of the patient that you're treating with, other comorbidities and other things that you have to look at. But
Yeah, because
natamycin,
many of these patients,
majority of the case, only natamycin also does work. And another thing that you have to remember is fungal keratitis does not behave like bacterial keratitis.
okay,
Response will take time to come up. It is
Mhm.
not that in 2 to 3 days you're going to see a magical response. It will take 5 to 7 days for any drug to show effect. So to wait and watch and then subsequently add drugs is a more justified treatment strategy than to adding up everything
or
together
shifting also.
in one go. Yeah.
Yeah.
Thank you so much. Do you have any comment from Bhupesh sir, Basak sir?
Rupesh, want to add anything? You are muted, Bhupesh.
Bhupesh sir, are we audible?
Sir, kindly unmute yourself.
Sir is actually joining us directly from OT.
No, no.
Yeah. So kindly unmute.
Sir,
At the bottom.
Yeah,
Yeah.
Yes, we can.
perfect.
Hello, good
So can
evening,
we
Welcome,
have
sir.
a
sir.
comment from
Good
you?
evening, Dr. Basir. Hello.
Thank you so much for joining us, sir. Can we have a comment from you?
Yeah, so I could not hear the exact question, but I question about the voriconazole and tamasuline. So,
Rupesh sir, what is your tips on the management of severe cases of these keratitis particularly in the pediatric cases?
pediatric fungal keratitis.
Yes, yes, sir.
So, keratitis, surprisingly, is not as difficult to manage as adult fungal keratitis. Somehow, whatever cases I have managed, they are easy to manage with topical medication. Probably their immunity or they present early. Cases I have seen, they do well with topical medication. Very rarely intervention cases.
I have one question. I just have a patient in ward admitted on my bed. It's a 2-year-old primary congenital glaucoma, operated PK both eyes, and has presented with fungal keratitis with desmatocele impending perforation. So we did a glue. We've started the kid on natamycin topical. And so what's your take? It's a 2-year-old child. Do we give systemic antifungal in this situation or not? And how to go about it?
Yeah, 2-year-old do not give actually oral medication or topical alone is quite good and restricted as a risk profile. So we give topical natamycin, and if at all you want to give what there is a graph infiltrate had fungus keratitis.
Yes.
So this patient is having
Yes.
graph infiltrate with fungal keratitis.
Yes. Yes.
Yeah, so graph infiltrate with fungal, they are difficult to manage as compared to the corneal infiltrate. So if you're taking graph infiltrate with fungus, many a times they don't do well. From the experience, very, very small, which is usually they are not because all the patients are using steroids and the moment you cut down steroids, they worsen. So these patients are uh, they usually need transplantation, and the outcome of transplantation is good because they subscribe inside the cornea. So if patients are having bad fungus and they are coming little later, as the scenario usually with pediatric keratoplasty is a fungal infection, I prefer to do early surgical intervention as compared to medical therapy.
Yes, sir.
But if you see normal patient, normal baby is coming, he is having, which is not very common as compared to having fungal keratitis for obvious reasons. And if they are coming, they do well with medical.
Yes, sir. Thank you so much, sir.
Thank you so much, sir.
Welcome.
I have comment and I want to share one slide with you.
Please, sir, please go ahead.
Comment is that again this geographical location of the patient and where is the patient and what is the type of fungus, that is very important. So if you start empirical treatment, initially you have to, and for single practice or something. So South India, Madurai study, or Bengal, it is more of aspergillus, they are more of fusarium. So your first line of drug will be a little different. Then voriconazole, Dr. Prajna used to say that voriconazole doesn't work here. I say voriconazole works in our place. So it is this kind of statement because it is clinical based evidence. This is no, and the patient improves. So our combination is like amphotericin B and voriconazole. You are giving one is azole group or another is choline group. So that is doing fine. So if you want to start with two medication and regarding that intracameral, intrastromal, everything, it is like anecdotal and nothing wrong in using it, but intracameral ampho, again, it probably induces more iris neovascularization later on. So whenever you do PK, you see a lot of bleeding when you do try to do PK. But oral voriconazole has got a limitation as well as maybe have some role, we do not know. But I want to show one slide. I have used oral voriconazole with therapeutic PK. Patient was advised eviscerations elsewhere. Elsewhere means from Bangladesh. She was a VIP patient, and I did operation. I opened the OT, operated at dead night because of lot of calls from Bangladesh. So I want to show that slide that sometimes if your approach is right, it may be miracle in therapeutic keratoplasty. Just I am showing that only one slide. So
Mm.
can you see my slide?
Yes, sir. Yes,
Okay.
sir.
Yes, sir.
Yes, sir, Viju.
This is the presentation. The patient presented, it is almost 14 years back. I always say this, that patient was a keratoconus patient, DALC was done there, and this was the fifth picture after DALC. And it was a fusarium. And next, after doing that, button analysis. PR was, that time was inaccurate. She was only 17. So an evisceration was advised, and from Bangladesh, they called me, Dada kuch korun. So you please do something. So I say, let's see one chance of therapeutic PK in this case. And therapeutic PK done. And this you see that after 1 year, the picture, the patient still follows me. The patient still follows me. And this is 1 year, and this is, you see that this is after 14 years. She is doing so well. So after 14 years, she is doing extremely well. So she has kept this photograph in her reading table. She is doing PhD now, and vision is 6'9". So that's what I want to say, that therapeutic PK, people say it is a bad surgery, why we will be learning this. It is not like that. Probably we need to take a call. So nothing is abnormal. So you can, I am unsharing myself. So this is the thing we should always remember, that therapeutic PK can do lot of things.
Sir,
So
it's a very important point. And sir,
True,
the
sir.
point that you have raised is being PR being inaccurate and still you went for surgery.
yeah,
I
yeah,
think
yeah,
Yeah.
yeah.
very
Why not?
important thing.
Because that time
Yes,
pain and agony and sometimes patient in a different mental state.
yes.
Right, sir.
So you have to take whether how many times you do, probably one quadrant, they will show inaccurate, but why not take a chance? If you have a tissue ready at your hand, take a chance.
I think it's a misconception with a lot of other people that if the PR is inaccurate, there's no need for surgery. But I think you've raised a very important point that even if the PR is inaccurate,
Answer me,
you
yes.
should
Thank
give
you.
the patient a
It's
chance.
honorable.
Yes.
Thank you so much, sir, for
This picture I
sharing this
always,
with
I have
us.
this kind of picture almost 7 in my library. All are like this, and those are extremely helpful to understand. Yes, if you have tissue, fortunately that day good tissue was there. I used that tissue. Only one tissue was available for next day surgery. I said, take a chance, and the thing is that I started voriconazole in this patient. So IV voriconazole followed by your tablet. That time knowledge about voriconazole was not there in the market, but I realized at that time then oral voriconazole cause visual hallucination and auditory hallucination. She was admitted in the hospital for 7 days and she had started this hallucination. So that is one point I do not know. Whenever you start voriconazole oral, so you should give caution to the patient. There may be auditory or visual hallucination.
Thank you so much, sir.
That was also shared by MS Srinivasan sir that sometimes it is so different. While this study was going in Madurai, that time I was also there for some reason. So one of the patient, they were admitted. He went to the open roof and tried to do suicide because he was thinking that his মানে, wife was died 2 years back. His wife was calling him to go to her. So that was a kind of auditory hallucination that time. So this is serious issue. So you should give a caution that auditory and visual hallucination along with oral voriconazole. Thank you.
Thank you so much, sir,
Thank
for
you.
sharing the gems with us. So moving on, I'll invite Dr. Sonali Prasad, who's working as cornea consultant at Divya Drishti Eye Center, Patna, to speak on viral keratitis. Over to you, Sonali.
Thank you, ma'am. Thank you, AIOS and Deepak Mishra sir, for giving me this opportunity. Are my slides visible?
Yes, yes, Sonali.
Sonali,
You are
go
audible
ahead.
too.
Thank you.
Doctor, just click on the screen to move the slides.
Stop sharing and reshare again. Okay. Very good evening, everyone. I'm Dr. Sonali, and today we'll be talking about viral keratitis, finding rationale in chaos. And we all know that viral keratitis is a leading blinding cause, infectious leading binding cause in the world. And viral keratitis is very important to know because it can mimic like other microbial keratitis and can happen in very different forms, and starting which drugs, steroids or antiviral, topical or not topical, can be a very tricky one, and that can lead to delay in the diagnosis and treatment of the disease. So it's an endemic, and around 1.5 million people are affected with viral keratitis, with a high recurrence rate of around 9.6 per year, with 90% of people aged more than 6 have HSV1 DNA positive. The mechanism can be either primary or secondary. In primary, mostly occurs in childhood, where it can be present as blepharoconjunctivitis or normal conjunctivitis, and then the virus remains latent in the trigeminal ganglion. Once it gets activated after any immune deficiency, it can lead to a secondary presentation. So depending upon the morphological, anatomical classification, we can easily divide it into epithelial, stromal, or endothelial keratitis. In the epithelium, we already know that the two very common forms, the dendrite and geographical ulcer. In the stromal, we have the necrotizing and the non-necrotizing variant. And in the endothelium, we have the disciform or the diffuse or the stellate capies forms. So in the epithelial keratitis, we have a very common presentation that we see in the OPD, the dendrites. And when these dendrites coalesce, they form a geographical ulcer. It's very important to stain these ulcers to differentiate it from pseudodendrites. So using a rose Bengal stain to stain the bulbs, which have the active virus particles at the bulbs, it stains well with a rose Bengal stain, and the base of the ulcer stains with the fluorescent dye. So it's very important to stain these ulcers. And coming to the stromal keratitis, which I said, it can be divided into immune stromal with an immune reaction to the stroma, or a necrotizing, easily if you want to classify with epithelium or without epithelium. So it can, all the rest of the non-epithelial keratitis that we come across has some or the other of immune reaction with them. And it can present at limbal vasculitis with a Weasley immune ring, necrotic interstitial keratitis, a disciform edema, or an endothelitis with or without trabeculitis. So endothelitis variant can have either in disciform, diffuse, or linear patterns. The limbal vasculitis, quite commonly seen in patients, is a local arthrus reaction, which is a type 3 reaction, and these rapidly resolve with topical steroids. The other variant, the other findings that we see in this stromal keratitis are the Weasley immune ring, which has antigen antibody precipitates, along with these are present with edema or neovascularizations. To look for the ghost vessels, it's a finding that we can see for the previous scars or previous infection. It's a very good history that we can take and see for a clinical finding of ghost vessels. These ghost vessels are nothing but empty vessels within the stroma and can happen during the course of the inflammation along with neovascularization. These ghost vessels, however, do not cause a decrease in the survival rate of the penetrating keratoblastes. The neovascularization again can give a clue of a previous recurrent viral infections, and these can progress in a subacute or chronic fashion, can be sectoral or a 360-degree, and mostly these neovascularization do affect the survival rates of the penetrating keratoblastes. The grave variant of the necrotizing stromal keratitis, it is associated with ulceration and dense infiltration. And even though these cases are very much difficult to differentiate from microbial keratitis, a lot of time, even after thorough treatment, they end up lining to thinning and perforation. And often a topical corticosteroids used in an injudicious manner can lead to hampering of the disease. The endothelitis that we come across can be linear endothelitis or a diffuse or disciform. The other variant is also a metaherpetic ulcer. These are also nothing but a neurotropic ulcer, which are non-healing epithelial keratitis because of the because of the excessive toxicity of the antiviral being used. So it's very important to find out the history of the patients. So whenever we come across asking for a history of recurrent redness or decrease in the immunity of the person, looking for clinical signs like ghost vessels or neovascularization or a footprint of HSV could give us clue of a previous infection. And these infections, the recurrence of these infections can happen days to years after an active keratitis. And this could also be present with any chronic recurrent persistence for a year. Even after you give a prophylaxis treatment, there may be low-grade inflammation, and after complete resolution, there might be instance of intermittent flare-ups also. So it is very important to diagnose, and diagnosing this patient can give you a clue which layer by finding out or doing a slit lamp examination and finding out which layer is involved. That could give you a clue how to treat this disease. So once you've diagnosed which layer or anatomical layer is involved in the viral keratitis, you should choose which topical therapy or an oral acyclovir or antiviral therapy to go for. Whether to start steroid in this particular categorized therapy or not, when to taper, how long to treat, and how to treat the recurrence. So diagnosing is basically, I think it is very much of a clinical examination that plays a role in the diagnosis of herpes keratitis or any viral keratitis. Along with that, to support our diagnosis in cases of confusing cases where we might suspect a microbial keratitis, underlying microbial keratitis, or with a secondary infection, a PCR or immunofluorescence can be helpful. A GeneStar stain can also be used when not available of a PCR or IPA. So in the past, we have nowadays that we are doing the evidence-based treatment of these patients were laid, the ground was laid by the hepatic eye disease, which was a multi-centric disease. And this disease was, the study was done to answer the 6 important questions on which we treat the patients of viral keratitis today. The first, the question that it answered was whether topical steroid were efficacious in treating the stromal keratitis along with topical antivirals. The second it answered was whether the oral acyclovir, when used with topical steroids or antivirals, was effective in stromal keratitis. The third, whether this oral acyclovir was effective in treating iridocyclitis cases. So when the conclusion of the non-steroidal, the patients are not on steroidal trial, it commented that the topical steroids in herpes keratitis can reduce the progression and it can speed up the resolution, but it had no effect on the final visual outcome. Whereas using of an oral antiviral to topical in herpes keratitis, again, however, it had no role in cases of stromal keratitis, non-necrotizing stromal keratitis. However, its role in ocular surface toxicity was recommended. So important consideration of HEDS 1 was a slow topical corticosteroid was very easily tapered, like very fastly tapered at 10 weeks. And around half of the patients in the group had a recurrence or a failure of the keratitis, failure of the treatment within 6 weeks after the cessation of the corticosteroid treatment of 10 weeks. So it taught us that treatment may need to be tapered more slowly, and on the visual outcome, there was no final result. The corticosteroid did not have any effect on the final visual outcome. So even if we started a little delay, it would not hamper the final visual outcomes. So taking tips from the HEDS 1 study, there was no rush to start steroids. A slow tapering should be done, and the lower the dosing becomes, the longer should be the tapering. So following that, the HEDS 2 was also conducted, and this studied whether oral acyclovir had any role on corneal epithelium to prevent the progression of stromal keratitis and iridocyclitis. The second question it answered was low-dose oral acyclovir helpful in preventing recurrent HSV keratitis? And third was to study the role of any external factors on the viral keratitis. So it commented that oral acyclovir were not indicated with patients with epithelial keratitis to prevent any stromal keratitis. And if it is used in a low dose for a longer time, the prophylaxis of a low dose antivirals can have a 50% decrease in the recurrence in cases of stromal keratitis, although no effect was seen in cases of epithelial keratitis. So concluding of the HEDS 2 study, the oral acyclovir had a very beneficial effect to reduce the recurrence of all forms of ocular HSV. And a risk versus benefit ratio is to be taken to impact the disease, and cost is to be considered for the treatment, and long-term prophylaxis is not needed for any epithelial disease. So in cases of summarizing epithelial keratitis, no prophylactic role of oral acyclovir. In stromal keratitis, a prophylaxis for 12 months decreases the chance by 50%. And to manage the stromal keratitis, a tapering of the topical steroids along with topical antivirals is recommended. In cases of non-necrotizing stromal keratitis, no additional benefit of oral steroid was seen. For the treatment of epithelial keratitis, we have treatment options of topical acyclovir 3%, ganciclovir 0.15%, trifluridine as well. Ganciclovir has equivalent effect as efficacy as acyclovir, only that the administration can be it can also be used at TDS dose with similar effects. So this was a Cochrane-based study that compared the role of all the topical antiviral treatment for the epithelial keratitis, and trifluridine and acyclovir were the most effective, and ganciclovir was equally effective as acyclovir. So in cases of a stromal keratitis, antivirals only have a prophylactic use. So the oral antivirals can be used over the topical antivirals only when there is a surface ocular issues, and a dose of 5 times or a dose at least of 5 times per day should be used when the steroid is being used for more than 4 times. So this was one of the summary from the evidence-based study published in the AAO by Harvard study done, and they recommended that for stromal keratitis, a therapeutic dose of corticosteroids along with prophylactic dose, that is 400 mg BD of tab acivir should be given for the without the epithelial ulceration. Whenever there is an epithelial ulceration, a judicious, a safer use of decreased use of topical steroid should be done. A limited use of topical steroid should be done along with a therapeutic dose of oral antiviral. And in cases of endothelial keratitis, a therapeutic dose of topical corticosteroid with a therapeutic dose of oral antivirals is recommended. The preferred clinical practice for a clinical scenario would be in cases of non-necrotizing stromal keratitis, using a prednisolone 8 to 10 times and then tapering it to 4 times. Up till the 4 times, use topical or oral acivir 5 times a day. And then you should put a prophylactic dose, and slow tapering of the corticosteroid should be done. So the benefit of antiviral is only till the timing we are giving it to the patient. And this should be remembered whenever we are giving it to the patient. And had said that at least for 12 months it should be given. But nowadays we see that many studies have recommended or have commented that the safer use of antiviral, so it can be given for a lifelong also. And another question is a valacyclovir and famciclovir equally effective as acyclovir? So studies have commented that oral valacyclovir 500 mg OD and oral famciclovir 250 mg BD are equivalent to a dose of oral acyclovir 400 mg BD. And to support this study, we have a recent study, that is a zoster eye disease, that has come, and the results of this study has been published in the July AAO. And this study was done to see the efficacy of low dose valacyclovir. The study was done to see the efficacy of low dose valacyclovir, whether it was effective in reducing the complications of HZO. But along with the reducing the complications of HZO, it has also seen effective in the role of decreasing the post-neuralgia pain, which is a very plus point of this drug. And recurrences, if you are getting in cases of viral keratitis, we must see if we are tapering the steroids too fast, or is we are giving the acyclovir at a sufficient dose, or are we dealing with a resistance stain. Although the resistance with acyclovir is quite low, but it is seen in immunocompetent patients, and there are some studies that have recommended using acyclovir at a higher dose for better prophylaxis. Studies from India has also been presented, where we have seen whether clinical practice is aligning with herpetic eye disease. And a lot of ophthalmologists, they do recommend that they follow the HEAD study for their own clinical practice, although using oral acyclovir less than 12 months is what they really prefer. In cases when we are planning for an ocular surgery in cases of viral keratitis, this is a very beautiful article that was published recently in the Survey of Ophthalmology, where the author has recommended at least a quiescence of 6 to 12 months. And if we are planning for a surgery in cases of post-viral keratitis patients, then if the patient is already on a prophylactic dose, then the patient is just needed to be given on a 400 mg BD twice post-surgery. If the patient is not on any prophylactic dose, then a therapeutic dose of 400 mg BD, 400 mg 5 times to be given before and after the surgery. So multiple studies have also studied the role
Dr. Sonali, can you please summarize? Yeah.
And studied role of cyclosporin has also been studied for viral keratitis, and recently to increase the graft survival, role of anti-VEGFs and fine needle diathermy has also been studied. So take home message from my presentation is we have to look for clues to support our diagnosis and not to fall in the diagnostic momentum. If the patient has already been diagnosed viral keratitis, it's not to be taken. Every case should be taken as a first case, and whenever in doubt, do a corneal scraping, and do not rush to start steroid and do not rush to stop steroids. Consider factors to stopping oral acyclovir should be seen, when was the last recurrence and number of recurrences, if the patient is one-eyed, precious graft, bilateral disease, or any evidence of renal toxicity. And one must not forget, till the timing you are giving antivirals, the prophylaxis is there, and after that, it can reappear again. Thank you.
Thank you, Dr. Sonali.
Thank you.
So we will combine, we will take up Dr. Rajshekhar's presentation after this, and we'll combine the both, and then we'll take the questions, just to stick to time. Dr. Rajshekhar, can you please share your screen?
Yes.
Mr. Sunil, please put a timer. Yeah, we can see your presentation, Dr. Raj. Please go ahead.
Okay. So, hello. The topic that I'll be talking is my slide visible and moving?
Yes. Yes, please go ahead. Yeah.
So I'll be talking about handling the exceptions, managing atypical keratitis. Atypical microbial keratitis, as the name suggests, they are clinically caused by uncommon microorganisms. They do carry poor prognosis because of less chance of clinical suspicion, limitation to identify with standard lab techniques, and absence of standard treatment protocols, hence creating a diagnostic dilemma. I'll be talking about, in brief, keeping the time in mind, nocardia, acanthamoeba, pythium, and atypical mycotic keratitis, and then followed by some interesting cases. It will be more of a case-based presentation. Coming to the part one, atypical organisms. Nocardia, they are thin, long, and branching filaments that stain weakly acid-fast on zeal and stain. Characteristically, they have this stromal infiltrate in the wreath pattern. Also, cracked windshield appearance can they have, and punctured epitheliopathy and pinhead-sized raised dots on the margin. Topical 2.5% amikacin is the drug of choice. These are the few cases, A, B, C being managed medically, and D and E with a failed therapeutic graft managed surgically. Acanthamoeba keratitis is a diagnosis is delayed and difficult because lack of specific clinical findings. Empirical treatment is not possible because of corneal toxicity of amoebicidal medications. It comes under various presentations as shown in these figures. IVCM is helpful, but it has got this operators experience and how they are judging it, how they are, many times it gives rise to overestimation of the disease. This is the case. This is a case where a 34-year-old male presenting with a non-healing ulcer, and it was managed medically. Patient was started on a 0.01% PHMB. We can use 0.02 also, along with 0.1% propamidine, and along with tissue adhesive and BCL. At 1 month follow-up, the patient is doing good. This is a surgically managed acanthamoeba keratitis where we did a AC tap and corneal scraping, and AC tap showed a PCR positivity for U bacterial genome. We gave antibiotics, but in seeing the worsening, we had to do a therapeutic penetrating keratoplasty, and the button confirmed multiple acanthamoeba cysts and few trophozoites. Coming to the pythiums are fungal-like oomycetes not containing ergosterol or chitin. Classically, they present with tentacular or reticular projections on ulcer margins going towards the limbus. They can give a peripheral furrowing and guttering. Plaque infiltrates with hypopion, mimicking it as a fungal keratitis, and tentacles, mimicking it as a acanthamoeba keratoneuritis. This is a case which was medically managed, and where we started the patient on topical 1% voriconazole, 0.2% linezolid, and 1% azithromycin topically, and by 40 days, we see a good resolution. This is a case which was managed surgically. Here, in the therapeutic penetrating keratoplasty, what we are doing, we are giving a single freeze-thaw cryotherapy, which is applied at the partial trephination mark. But somehow we got a recurrence in this case. And by 1 week, we confirmed that this is a pythium because of the broad ribbon-like folds with rounded ends, which were noted. Somehow the conservative management was continued in form of linezolid and azithromycin. The patient was healed medically, and by four months of inactivity, we did an optical PK. Coming to the keratitis caused by atypical fungus, we know that filamentous fungus are a significant cause of the keratomycosis, followed by dematicious. As discussed earlier, we are giving 5% natamycin, combining it with 1% voriconazole, regular debridements on each visit, oral antifungus, and this targeted intrastromal intracameral therapies have their own, their adjunctive. This is an alternaria keratitis, which presented with this black plaque. We started him on 5% natamycin, followed by a voriconazole. Plaque debridement was done on every visit. Desired remission was not noted by 2 weeks, so we went ahead with a superficial therapeutic keratectomy along with an amniotic membrane over the denuded surface. Intraoperatively, we also gave intrastromal and intracameral amphotericin B. At 1 week post debridement, we can see, and by 2 months, the resolution was good. This is the Calvularia keratitis which were both managed with medically as well as tissue adhesive was used. This is a scedosporium, which is difficult to treat medically, and they need surgical interventions like TPK, as shown in this figure. This was a recent case of Colectotrichum truncatum, which we found, and they work very beautifully with the topical antifungals of netamycin and voriconazole. This is a picture showing 1 month follow-up. So the caveats are classical signs may be uncommon, but if encountered, one should be ready. All ulcers must undergo routine scraping and culture plating if possible, confocal and PCRs if available, close follow-ups, and proactive in taking up therapeutic grafts for unresolving ulcers. These are my references and for further reading. This is some atypical scenarios to think out of the box. This was an interesting case of Thygeson versus microsporidia, where a 15-year-old male who was being treated elsewhere as a recurrent viral keratitis, having this coarse granular raised SPKs, keeping the working diagnosis as microsporidial superficial keratitis, we did a diagnostic epithelial scraping. All microbiological tests were negative. Then at one month of follow-up, we gave this fluoromethanol acetate drops because of non-resolution of symptoms, and the coarse SPKs cleared off, giving rise to no underlying scarring. Child had this similar 3 episodes of recurrences in the 2 years. So the differentials that we were looking at were microsporidial superficial keratitis, viral keratitis, and Thygesons. Thygeson SPKs were more in the point of favor, having this chronic course of exacerbations and remissions, healing without scar formation, no response to antibiotics, dramatic response to topical corticosteroids, and absence of conjunctival hyperemia or any preceding decreased immunity incident. Even the in vivo confocal microscopy showed characteristic features such as superficial epithelial cell layers giving a starburst-like appearance, numerous Langerhans cells at the basal epithelial cells. We did his epithelial debridement with amniotic membrane on the 5th year of his recurrence, and then kept the patient on tacrolimus. Past 3 years, there has been no such recurrences. Even the IVCM have improved. This is a 7-year-old timeline. So viral keratitis is a great mimicker, and before starting steroid medications, scraping is very important. Coming to the next case, ball in the anterior chamber, not always fungus. This is again a 72-year-old female who had undergone a cataract surgery 6 months back, and she came with a 0.5 into 0.5 mm ball-like structure over the iris surface. It increased threefold within the 5 days, and a provisional diagnosis of anterior chamber fungal ball was made. We did an ultrasound where we find moderately reflective dot and clump echoes in the vitreous. Diagnosis of chronic endophthalmitis of fungal origin was made. So we did a left eye IOL removal with anterior chamber wash and vitrectomy with intraocular antibiotics. And post-operatively, we treated with topical natamycin, voriconazole, and moxifloxacin. By the end of 1 week, we were not having any organisms grown, but at the 12th day, we found that's positive for MSSE, methicillin sensitive staph epidermidis. So we started on 5% cefazolin, and we find that by 40th day, there was a clear cornea and quiet anterior chamber. So ball-like exudates in anterior chamber are most commonly seen with associated with fungus. So nocardia, MRSA, and MSSE are nosocomial pathogens commonly associated with post-operative endophthalmitis. And this is the last case case of spurious drops. This is a moxie and a lotepred drop. This was a 48-year-old female who, just after giving a 1-drop installation of a single topical moxie and lotepred suspension, she presented with the figures shown. It was a kind of grade 3 and 4 Duas classification. Even the litmus paper test showed us acidic response, and we started her on topical dexamethasone, moxifloxacin, cycloplagics, and copious lubrications. A medical bottle was checked for any evidence of tamper. None was found. So at 1 week, looking at the picture, scleral ischemia, we did an amniotic membrane Tenon's advancement, and in the meanwhile, the drug was sent to the biochemistry lab, where the pH was found to be 6.4, and the vial was also sent to ocular pharmacology lab at RP Center, which was found to be having an hyperosmolarity and growing aspergillus flavors. Despite the given report, we continued with topical steroids and 4th-generation fluoroquinolones. Patient responded well to the therapy at 1 week follow-up. At 1 month on removal of BCL, we see a healed surface with no evidence of infection. So the caveat is microbiological analysis is the crux of evidence-based treatment. But in situations where clinical picture and lab analysis differ considerably, we need to monitor the patient even more closely. Thank you, everyone.
Thank you so much, Dr. Raj Shekhar, for sharing the Pandora's box of cases. Dr. Raj is working as associate consultant at Shankar Nethralaya, Kolkata. Any comments or questions from the chair and esteemed panel?
Thank you.
So, any comments, Basat sir?
I have a comment for Sonali. Sonali is there. Yeah,
Yes.
it's a nice presentation and you have covered everything. And indeed, nowadays the valacyclovir is more choiceable than acyclovir because of better compliances. Only the disadvantage is little bit costlier than acyclovir. Otherwise, if you want to give for prolonged period, some of the patient is getting for 4, 5 years, 6 years, 7 years, one-eyed and very vulnerable patient. And those cases, valcyclovir is a better choice because they once day and you have to go with the body weight dose schedule, and they actually do well, probably better, because if you read the article, it is the bioavailability is 5 times higher than acyclovir. So it is a pro drug. It converts into acyclovir, but the only thing you have to consider for kidney function test, renal function test every 3 to 6 months. That is one side of this. I want to share a little different story that recently, maybe within last 6 months, how many of you have seen CMV endotheliitis or CMV keratouveitis? Mode of endotheliitis with little bit of uveitic element. How many of you have seen personally? Sharon,
Sir,
how many? Only one. No, I cannot hear you. You just unmute yourself.
you are unmute.
Just one or two, sir, not more.
One or two. And Pranita?
Sir, we see a lot of viral endothelitis cases, purely just endothelitis, but we don't go for the CMV investigation.
This
But
year.
recently I had a patient which was worked up and it was proven to be CMV viral endothelitis. It was admitted in ward and their reports were positive for the CMV PCR.
What
So
about this?
that is a different story nowadays. I have seen in the last 6 months 4 cases. And if you consider my last 25 years, I have seen only 4 cases. And this 6 months, and one of them is doctor, one of them is doctor's father, and 2 of them is in general category. Probably, and all proved by PCR. All proved by PCR, none of them. And then I have started this Valgan and valganciclovir and only topical ganciclovir. But the thing is that probably because CMV, out of 100 people, we have CMV. It happens with immunocompetent patient. The other category like retinal CMV retinitis with immunocompromised patient, but viral with little bit of more of endotheliitis than uveitis, and you see typical coin lesion or lineal KPs and high IOP. These are basic 3 criteria. High IOP, all these HSV, endotheliitis, by and large, they do not give high IOP. So if you see high IOP in a case of HSV treated somewhere else and still high IOP means they are uncontrollable with 3-drug, 4-drug regimen, that kind of high IOP. So you have to consider ACTAP or PCR repeatedly. One of my patient is actually second time she was positive. She is a gynecologist, leading gynecologist, and her endothelium actually decompensating recently. So my question that you probably will now search for it, probably COVID has changed because all of us, it is opportunist, it is within our body, 80% or 70% of us harbor them. Probably something has triggered. So I'm very cautious nowadays. I'm not in UVA clinic. They come more of endothelitis picture with little blurring of vision, more of little corneal edema. Then I see few KPs and those are typical pattern. Then I go for PCR. So word of caution with that, all HSB endothelitis probably are not HSB endothelitis. They are also look for CMB, and if the IOP is high, strong suspicion, and prove it because the cost is expensive, very, very expensive. So you have to prove it before convincing this patient, yes, you have CMB endothelitis and it is infective varieties and you have to go by treatment. So open your eyes.
Thank you, sir. Thank you so much.
Thank you,
Can we
sir.
have Dr. Sharon's presentation, please? So Dr. Sharon does not need any introduction. She's a senior consultant at Narayan Nethralaya, Bangalore. Over to you, Sharon, ma'am. We can see your presentation. Yeah.
Okay, I hope my slides are visible and I'm audible.
Yes, ma'am.
Yes.
Thank you so much to Dr. Deepak Mishra and Dr. Prashant and AIOS ARC for this wonderful opportunity. Thank you, Dr. Basak sir, to be here all through this webinar and give your words of wisdom. So I'm going to shift gears a little. It was a brilliant set of talks till now. So what we wanted is that, the most common scenarios that everyone is facing and how to deal with them. So collagen cross-linking has become a very, very common surgery which is performed all over the country and around the world. And it has, in a sense, revolutionized the management of keratoconus and other eclectic corneal diseases. Of course, the aim is to prevent the progression of ectasia and thereby, preserve vision. And the most common protocol that is followed is the epithelium off protocol. And it is definitely a very, very safe surgery, and sight-threatening complications are rare. However, when they happen, it can be very, very severe. And one of the most dreaded complications of this procedure is a keratitis, which can have devastating effects because many of these patients and most of these patients are very young. And to have something which is sight-threatening in them, it's really quite difficult. So before we move forward, we know that infiltrates in these cases specifically can be both sterile or infective. And it is very, very important to try and differentiate between these two entities because our management would be poles apart. So the points which help us differentiate between the two is the amount of congestion. Of course, these are not hard and fast rules, but they are clues to help us diagnose. The amount of congestion may be more in an infective. The location of the infiltrate, which very often mid-peripheral or towards the periphery, could be a sterile one. You also get some sterile infiltrates along the edge of your epithelial where you've debrided, whereas the infective may be more central. The morphology of the infiltrate, and through the wonderful talks till now, you have seen that the kind of, the morphology of different kinds of ulcers do always give us a clue. And even in this case, however, here we have the extra confounding factor because of the UV light which has been applied, and in some cases, the steroids which may have gone. An overlying epithelial defect is again more towards an infective pathology, and the AC reaction can be there in both. But if you have an hypopion, please do think more in terms of an infective. So to recap what I just said, so this is a case with sterile infiltrates on the cornea, and you can see that they are much more discrete, well circumscribed. There's no epithelial defect over the infiltrate directly. In contrast, the infective one, which is the lower image which you see, even though the distribution of infiltrate seems to be similar in the mid-periphery, but here you see that they are a little more irregular kind of infiltrates. They are tending to get coalesced. there is an epithelial defect, there can be variable depth of it, and a lot more congestion and inflammation. The patient will be very, very symptomatic. This is how that they can very, very rapidly progress. And this is over a day or a couple of days that, they sort of coalesce and form this large infiltrate if it's not picked up fast. So what are our risk factors for having an infective infiltrate? The most common is, of course, the loss of the epithelial barrier, which is a very important defense against microbial invasion in our corneas. There are very few bacteria that penetrate an intact corneal epithelium, and here we are debriding the epithelium during the cross-linking procedure, so it removes that barrier. In addition, because of the UV light and the use of steroids in some cases, there can be an altered ocular flora. In addition, some or many of these patients would have a lot of allergy, which has been treated with various drops that could have altered the ocular flora. BCL use post the procedure can act as a depot or can act as a reservoir for infection. So that could add to the risk of infection. Perioperative hygiene, very often these patients, they are very scared to touch the eye, rightfully so, or they may not be able to clean it properly. And that could result in some infections. And of course, if they have some altered immune state. Now, what are the common organisms that have been identified in these cases of infective keratitis post cross-linking? The most common is Staphylococcus, and that could be due to the fact that it is one of the normal, very common bacteria found on our ocular surface, even in normal conditions. And in case when there's an altered, all the factors that we talked about, they sort of flare up. So both the Coagulase negative staph and Staph aureus, including resistant strains, and I'll show you a few cases of that. Streptococcus, you can get Pseudomonas, and of course, you can get all the infections. So acanthamoeba, fungi, even herpes reactivation is known to happen post cross-linking, and we do need to pick up these cases and treat them early. Now, what is very important to remember is that even though in our head, Staph aureus is a gram-positive organism, it may be, less virulent than a Pseudomonas. So therefore, it would be easier to treat. That thought process will need to change in these cases because, first of all, they behave very, very aggressively, even though it's Staph aureus, and they tend to melt very fast. So it needs to be treated. The other problem is that very often these cases are resistant to the fourth generation fluoroquinolones that we have, and we may have to look at alternate treatment. And therefore, support from microbiology with the culture sensitivity does help a lot in these cases. And there have been very nice papers from India and abroad which talk about the profile of the infections that we see. Now, even to add to our problems and woes is that methicillin-resistant Staph aureus has made its way even into these conditions. And there have been cases where it has been an MRSA which has developed a perforation, and this patient may require then to go and have a therapeutic PK. And, if you see where they're coming from, where in their head, it was a small procedure, which was a cross-linking, and ended up having to have a therapeutic PK. It is really something that we want to avoid as much as possible. Pseudomonas keratitis can occur following cross-linking, again, because of all the risk factors that we have talked about. And of course, patients, I think it is very important that we impress upon patients the need for a good follow-up, close follow-up, taking care, post-operative care in terms of how to put the drops or how to maintain hygiene is extremely important. Now, UV light, can be a potent stimulus for reactivation of even viral infections. So sometimes you may not realize there could be a small scar on the cornea, which is a marker of an old HSV keratitis. And or sometimes nothing might be visible, but UVA light is a potent stimulus for reactivation. And then you add on topical steroids, which can be additional risk factors. So you can get a reactivation of HSV keratitis as well. In addition, acanthamoeba keratitis, which has been so beautifully shown in some of the talks, can also occur in this, especially if the patient is not careful and goes and washes their eye, then it's a potential risk factor. Now, one important question that it gets asked is whether to continue steroids right in the initial post-op period when the epithelium is still, not healed up or not. And there are enough groups, who have studied this, and there is still no consensus, but the use of BCL and topical steroids prior to healing of epithelium is shown to be a significant risk factor, and vice versa. If you didn't use the BCL and delayed the introduction of steroids, it could reduce the risk. That being said, there are, I know enough experienced doctors around the country and the world who do both and do not have infection. So it definitely cannot be a one-off. So when you see a patient who has an ulcer, you approach it like any other infiltrate that you see on the cornea. So you have to do a corneal scraping. So one dictum that we do follow is that before removing the bandage contact lens, and we do use a BCL in our practice. So before removing the bandage contact lens on the day when the patient is coming back for follow-up, we do examine the patient on slit lamp, make sure everything looks fine, the epithelium is healed nicely, and then remove. So that is twofold advantage, because one is, of course, you can see if there is a problem there. And secondly, if the BCL needs to be plated, then it can be directly taken from the eye and plated onto your culture plate with the inner surface down on the plate, which is the part which was touching the cornea. The scraping follows the same rules. You do the gram stain, the KOH, and the bacterial and fungal cultures. Till you have your culture reports, we do have to, try and manage the patient. So some amount of empirical treatment may happen. Precautions to avoid infections are, if you are putting a BCL, keep a close watch. So you can, keep them on close follow-up and call them. We usually call after the second day. Explain warning signs and symptoms to the patient, because anyway, they'll be having pain, so they may not realize that something else is brewing in the eye. Topical steroid, it is the surgeon's wish, and they can or cannot start, but if you're starting, then again, keep on close follow-up. And if there are any severe allergy or lid-related issues, they ideally should be treated as much as possible before procedure to reduce the risk of a problem. Infective keratitis, preferably based on microbiology, you start the antibiotic and antifungal in high frequency. Hit it very, very hard so that, the chance of it, the infiltrate growing and you going out of control is less. As with all ulcers, you have your adjuvants of cycloplegic or lubricating drops. Doxycycline helps a lot in these cases because it has a role because of its anticollagenollytic activity. So the melt reduces to an extent. Inflammation needs to be controlled, but of course, avoid an NSAID drop. It can just worsen the situation. And here is something which is, important, is that once you start, especially in bacterial ulcers, which are proven bacterial, once it starts healing and you're seeing the early scarring, we need to start the topical steroids to reduce the risk of scarring. However, the dictum is that in case you feel that there is too much of a risk of the infiltrate increasing or flaring up, then wait and then start the steroid. Of course, in extreme situations, you may have to do a therapeutic or a patch graft in case of a perforation, which can happen. A few case scenarios to highlight. This was an 18-year-old boy who underwent a conventional epi of cross-linking. Third day post-operative, he presented with this picture with worsening pain, redness, photophobia. And you can see the classic, very fluffy kind of infiltrate with the feathery margins. And this, without a doubt, even before you send for microbiology, it's going to be fungal keratitis. And sure enough, with the corneal scraping on the KOH preparation, it showed fungal keratitis. He was started on natamycin and voriconazole because there was hypopion, and we wanted to hit it as hard with an oral antifungal. And thankfully, it healed well. There is some scarring, but we know that the cornea remodels beautifully. And so over time, the scarring does reduce quite significantly. This is another case who underwent conventional cross-linking, came back on the third post-operative day, and this you can see is a much larger infiltrate. It has a grayish appearance. Patient had severe pain, lid edema, inability to open the eye, a lot of hypopion and AC reaction, and corneal scraping showed a gram-positive cocci on the gram stain. Culture showed Staph aureus, which was sensitive to vanco and ciprofloxacin. BCL was plated as well. So this was treated as per the sensitivity, and over time, it does scar, but you can see that the scar is quite significant. Once it was almost scarred, we started the topical steroid to reduce the residual scarring, and this is about 3 months post the infiltrate, and we see that there is at least a reduction in the amount of scar, but more importantly, the infiltrate has healed, and we could avoid having to go for something like a therapeutic PK. However, sometimes before we can do anything, as I said, these cases have a lot of melting of the collagen, and they can come in with almost a perforation or a near perforation. And this patient had, as you can see, the area of thinning there, and we did a multi-layered AMG and healed. So in these cases, there are a number of challenges. One is, of course, the first decision is whether it's infection or just an inflammation. We know we have to find out what organism is present, because as we saw, there can be a lot of different infections that may be present, and you can also get a polymicrobial infection. And now we also have to deal with the problem of drug resistance, because more and more of the bugs that we have are resistant to our regular medications. So take-home points would be a lot of counseling pre-operatively itself on the post-operative care and follow-up required, on the hygiene and the red flags in case they have a problem. If possible, it would be better to avoid a bilateral surgery unless absolutely essential, so that you reduce the risk in these cases. A close monitoring with a high index of suspicion for any sort of infection. And if there is an infection, then aggressive therapy to try and control it as much as possible early. Thank you very much for a patient listening.
Thank you so much, ma'am. So any comments? Is there any comments? Any comments, sir?
Sir, you are muted.
Dr. Aditi, you will be going next.
No, sir. Sharon.
Yeah.
No. Sharon has presented so nicely. Nothing to comment, actually. She has covered everything. So still there is an area of, a gray area of the CXL, PAC CXL, whatever. Now we have tried, many people have tried, a lot of studies. Still, we believe that probably it doesn't work. Probably it does not occur. Maybe the virulence of organism is different in different countries. And our organism, we know they are not.
Yeah.
Probably that is the reason. Otherwise, it is a try. You can always try. But if you have tissue, so then again the question comes again that we know that wherever there is an abscess, from our basic knowledge, try to remove the abscess as far as possible. You can do a therapeutic bulk also in selective cases.
Early,
You can see the exact border of posterior limit. You can do, you have plenty of tissue. Because of that thing, is it lacking in other places? They are actually trying in different modalities. Probably, that is my sense of why they are thinking other way around. Because they have not therapeutic tissue, or any tissue is available in many countries across. You know that if you study that paper, Gain et al. Mentioned categorically. So many countries, European countries, you see the Middle East, other European countries, lack of tissues. So even a therapeutic tissue is costing them $1,000+. So probably that is the reason they are trying in different modalities. But we know that we have tissues. So our aim is that to reduce the patient total duration of the disease process. If we can reduce the disease, because they are daily labor, wager, and everything.
Yeah, they can't keep coming.
They cannot come. Their attendant is also daily wager. So we cannot go by this kind of, okay, we'll see that. So we'll try our best thing to go with the medical therapy. And everybody has a kind of limit or something. We'll try this period, that period, and this. Then we'll straight go. Probably we will do better justice to this patient rather than trying different modalities. Where there is no tissue, you have to try. But that is with our people, our thinking process should be little different than the whatever literature says. So that is my take home.
Thank you so much, sir. So may I now invite Dr. Aditya Pradhan to give us the saransh, and he's a cornea consultant at the Shire Hospital. Over to you, Dr. Aditya.
Yeah, so am I audible?
Yeah,
Yes, yes.
you're audible and we can see your slides.
So
We're
good
moving.
evening to everybody, and thank you AIOS ARC for this opportunity. It's always a great feeling to present any talk in front of my mentor. So thank you, Dr. Basak sir, for being here till the end. So I'll just give a brief overview of the key trials and advances which have occurred the past decade or so, or even more, in the infective keratitis pharmacotherapy. So I have no financial interest to disclose. So basically, what is the big deal about a clinical trial? So why are they important in the field of evidence-based medicine? Is because they help us in evaluating new treatments and drugs. They ensure that the patient safety is maintained at all times. They help in advancing the medical research. Whatever existing treatments we have been improved because of clinical trials. They are very important in addressing certain public health challenges, the most notable of which was in past memory, the COVID epidemic, in which the trials helped us in getting the vaccines quite quickly as compared to the normal way. They're important for regulatory approval and market availability, and also they have economic and scientific benefits for the community. So, and why are we talking about infective keratitis is, although it's a rare condition in the developed world, it is very common and a neglected tropical disease in our part of the globe and a silent epidemic, so to say. It's the fifth leading cause of blindness worldwide. More than 1 million cases of fungal keratitis are seen every year. It is highest in the continents of Asia and Africa. About 8 to 11% of the patients need a eye removal procedure, either it's a evisceration or enucleation. So this is data from 3 case studies. So if you extrapolate it to this figure of fungal keratitis, it's around 1 lakh eyes every year are being lost throughout the globe because of misdiagnosed, underdiagnosed, or undertreated, wrongly treated microbial keratitis. So this is a very sobering statistic that we are losing almost 1 lakh eyes unnecessarily, maybe just because of lack of proper diagnosis or proper treatment. So this map is showing the prevalence of fungal keratitis as a percentage of all microbial keratitis throughout the world. It's a color-coded map. So the red regions are those in which more than 45% of the total microbial keratitis cases are due to fungus. So we have India, we have China, we have the Southeast Asian countries, some countries in Africa and Mexico and Paraguay in the South American continent. So those with a tropical climate are being more afflicted with the fungal keratitis, and they also have a higher burden of general microbial keratitis. So the landmark studies which I will be talking about are basically a lot of short forms here. So the MUD trials and the HADS has been discussed before today by Dr. Pranita and Dr. Sonali. So I'll skip those. So we have the SCUD, the ASICS, the PAC-CXL and CLAIR, the ODAC and the ZADS. So I'll come to the short forms, the long forms very quick. So the first is the steroids in the cortical ulcer trial. So here is basically, this was performed in Madurai, in which the initial trial was to assess the effect of adjunctive corticosteroids in bacterial corneal ulcers. It was a randomized placebo-controlled double-masked multicenter trial. So 500 patients with bacterial corneal ulcers were enrolled in the study. So at the 3 months between the placebo and the corticosteroid groups, there was not a significant difference in the best spectacle corrected visual acuity. Maybe there was a potential benefit in severe ulcers whose visual acuity was less than 20 by 400. No safety concerns were noted, but the area is very gray and mostly there was no benefit. And in the subset group, there was nocardia keratitis, which was studied, and the impact of steroids on that. So 55 patients out of 500 which cultured confirmed nocardia keratitis. They had a better baseline visual acuity to begin with, but they showed a less improvement with steroids. And at the end of 3 months, the use of corticosteroids worsened the outcome, especially in the subgroup of no cardiac keratitis. And the secondary 12-month clinical outcomes of the first SCUT trial is basically the long-term outcomes of corticosteroid use. So that is at the end of 1 year. So again, the same cohort of 500 patients. So no significant difference in the visual acuity was seen at the 12-month period also. No significant differences in the scar size or the contrast sensitivity. The safety was favorable, but eventually the trial did not show any positive effect for corticosteroids. Rather, it was harmful if you are dealing with no cardio. So this is the ASIC study. It's not strictly a clinical trial, but I've included it because it's a huge sample size and huge diversity as well, because 13 study centers and 30 sub-centers, 8 Asian countries were covered. Basically, these are the ones, the red areas on the map I have shown before, 6,563 patients. So basically, they just had a demographic data collection, and they found out that majority, the afflicted with the microbial keratitis were male patients. The risk factors, as we all know, were trauma and contact lens wear. Bacterial keratitis was in 38% of the patients, and fungal keratitis was present in 33% of the cases. Fusarium, Pseudomonas, and Aspergillus were the most common across the 8 countries. Now, another sobering statistic was that out of these eyes, 628 eyes needed to have a therapeutic corneal transplantation, in which at the end of the study, 46% of the grafts failed by the end of the study period. So almost 50% of the grafts failed. So basically, the conclusion was that mostly the male population is affected or engaged in outdoor work, mostly farming, and it is very frequently related to vegetable trauma. You have both bacteria and fungus, and the visual acuity is often poor, the recovery because of the scarring. And if you do in a hot case, that is a therapeutic graft, it has a high failure rate. Almost half of the grafts that you will do will fail. So this is a very important statistic for everybody to know. Coming to PAX-CXL, which is photoactivated chromophore keratitis, so the treatment by cross-linking. So there are different permutations and combinations of studies I have found on the literature search. Some have done it for purely bacterial, some have done it for purely fungal. Some studies have studied a mix of both. So I'm just showing you how two studies can give you two different perspectives. So basically, the first one I'm just included is published in Cornea in 2015. So this was a prospective interventional study with Iran as the setting. So moderate bacterial corneal patients were included. So two groups, the experimental group just had the PAX-CXL as the primary treatment. The control group, only standard antibiotics, whatever was the institutional protocol. So they looked at the healing rate, the infection resolution, and the reduction in the ulcer size. So they noted that the experimental group significantly reduced ulcer size and improved the outcomes with no major safety concerns. So they showed promise in this. The other study which I'm showing is basically a single center randomized control trial from Madurai, the Arvind group. Again, the population was bacterial keratitis, 80 patients with culture proven bacterial keratitis. The experimental group was CXL with topical antibiotics. The control group was the standard antibiotic therapy as per the institutional protocol. And the cure, microbiological cure at 24 hours via repeat cultures was the primary outcome. So compared to the control group, the experimental group did not improve the outcomes. And between the two groups, there was no significant difference in the healing rates. It was well tolerated, but it does not give you any extra advantage compared to the conventional therapy. So two different trials, but two different perspectives and outcomes, and two different geographical locations, which is very important. So this is basically another organism, which is acanthamoeba. So this is the ODAC trial, which is the orphan drug therapy for acanthamoeba keratitis. We all know that we are using PHMB and propamidine, that is also known as Brolin. In the treatment of acanthamoeba keratitis, the treatment is often prolonged. It was just published last year. So basically, a prospective randomized double-masked active controlled multi-center phase 3 trial across 6 European countries. So basically 135 patients with a diagnosis consistent of acanthamoeba keratitis. So two groups. So basically the standard concentrations which we are used to in PHMB is 0.02%. In this, the experimental group had an increased concentration of 0.08% with placebo, and the control group was the standard combination therapy of 0.02% of PHMB with 0.1% of propamidine. And at the end of 12 months, the medical cure rate was the primary outcome. That is 90 days after the discontinuing of anti-inflammatory agents and anti-amoebic therapy. So basically, between the two groups, 86.6% and 86.7%. So it was shown that it was non-inferior. 0.08% was non-inferior to the standard therapy and the added convenience of just one single drug. And the failure rates between the two groups were the same. No adverse drug events were noted. So this is now currently a very landmark trial because it has shown that just by increasing the concentration, you can just adopt a monotherapy, which is as effective as the combination therapy for treating AK. So obviously we don't have this drug yet in our country, but there they have a GMP center which is manufacturing this for the trial. And let's hope that it gets commercialized and becomes available in our market as well. This is not published. It was briefly touched upon by the previous speaker. So this is the ZDDS, that is zoster eye disease study, which studied two important things. Basically, the primary objective was the seeing the benefit or worsening of low dose valsacrovir at the end of 12 months, that is 1 gram per day. And also the secondary objective was to assess the persistent benefit at 18 months of oral valsacrovir on the effect of post-herpetic neuralgia, which is a very devastating complication. So they had 4 groups based on the age and time of onset. So one was age less than 60, one was more than or equal to 60. The other group was either less than 6 months or more than 6 months. So a lot of participants, the primary endpoint was new or worsening of the disease at 12 months. And the endpoint secondary was the post-herpetic neuralgia at 18 months. So if you see the key findings at 12 months, the primary outcome was, they didn't see a very overall treatment benefit in preventing new or the worsening disease, but younger group with a more recent onset, there was a good benefit at the end of 12 months of giving 1 gram of oral valsacrovir daily. But at 18 months, there was a significant benefit in preventing the new or worsening of disease, especially with post-herpetic neuralgia. It reduced the prevalence in younger patients at 1.5 years and also reduced the amount of neuropathic pain medication that most of these patients get at the endpoints of 12 and 18 months. So the current recommendations by ZDDS are 1 year of valsacrovir 1 gram per day is recommended for immunocompetent adults to reduce the new or the worsening of existing keratitis or iritis. And it also has a good secondary benefit at the end of 18 months for reducing the herpetic neuralgia and reducing the dependence on neuropathic pain. No study medication related adverse events were noted. So this is a very landmark study. It is yet to be formally published in any journal, but this is from the NYU website. So this is what I could gather from the study, the results they have disclosed. And what are the advances is basically we have advances on 3 fronts. One is the mode of drug delivery, the treatment of the microbial keratitis, and the diagnosis. So we'll start with the diagnosis. So currently nanotech is the hot word. So we have nano biosensors, we have nano imaging probes, in which this is advocated to improve the sensitivity and specificity of the diagnosis of which organism you're dealing with. In the modes of drug delivery, just so that the penetration of the drug, especially the antifungal agents, you have nano emulsion formulations, you have liposomal, hydrophilic and hydrophobic drugs can be encased within the liposome. You have polymeric formulations, you have solid lipid nanoparticles, which is lipid is the carrier. You have nano suspensions, you have nano micelles, you have dendrimers, neosomes, cubosomes. These are all different formulations of drugs based on nanotechnology. And the last part of the advances is treatment, in which you have nano wafers, you have microneedle patches, and drugs which impregnated into the polymer contact lenses You just place the contact lens on the ocular surface, the ulcer, and you get a marked improvement in the signs and the symptoms. The same contact lens can also be modified to give you the diagnosis depending on a color change. It gives you a particular color which tells you which organism is currently the cause of the corneal ulcer. And you have the drug delivery systems in which the bottle contains the drug which is enclosed within the nanoparticles. So some drugs are thermoresponsive. Basically, the bottle is at room temperature. The drop falls on the ocular surface, it reaches the physiological temperature, and the drug is liberated and attacks the bacteria, and the bacterial death occurs. You have enzyme responsive, in which it interacts with a particular enzyme released by the bacteria that triggers the drug release and causes the bacterial death. You have pH responsive, in which, because of the infection, the pH is altered. As soon as the drop touches the ocular surface with the altered pH, the drug gets released and the bacterial death occurs. And you have reactive oxygen species, which are released by the reaction between the macrophages and the bacteria. So the drop falls on the surface, the drug is released. Especially this is important in fungi, in which the penetration is poor. But since this is based on ROS, the drug gets released on time and the fungus is killed. So it is a proud moment that certain advances in the nanotech field are being done in our country also. So as discussed by the previous speaker, natosol is basically a aqueous formulation combined with cyclodextrin of natamycin, which has higher penetration compared to the suspension form which we are using. So this is a prospective interventional study in which 3 groups. So one group received just 5% natamycin, the group 2 received natosol 1%, and the group 3 received the conventional nata and voriconazole. So in this, the time to epithelialization, the ulcer healing, they have shown that the 1% natosol is showing shorter time to epithelialization compared to the other 2 groups. And coming to the last part of the presentation, AI is the buzzword everywhere. So you have this online calculator for infectious keratitis called as the C-Duke. So in which you have corticosteroid drops, the vision, the ulcer height and width, and whether you have the culture reports, and gives you a percentage risk and when you need to intervene surgically with this. And your smartphone app based, AI based keratitis screening, in which you just take the photo and it will tell you probably the organism by using different algorithms and AI. And also the gut microbiome is now implicated in the various presentations, why in some individuals we get a response and why some individuals we don't get. Maybe Dr. Bhupesh was talking about pediatric patients being less severe with fungal infections. So with that, I'll just conclude my talk. Thank you so much.
Thank you so much, Dr. Aditya, for summarizing such a big topic. Thanks a lot. Over to you, Deepak, sir.
Thank you. Any question for the panelists? I think everything is covered. So it's time to.
Yes, Aditya is always a great curator. He always curates nicely. So it is wonderful. So whenever people will get this summary, they can well understood that what is happening across the world. So always you have to, because our country is totally different, and these microbes, the gut pathology, the whatever, totally different. So you have to your own population. So yourself, you have to make an algorithm, like your patient, your geographical area, your bugs, your own formula. So that's what my suggestion. The formula will not, like Bangalore formula will not happen in Barakpur. Similarly, Barakpur formula will not go with the Delhi formula. So you have your own formula. So far, patient is going good with your treatment, current methodology. Continue and get you updated always from the what is, and try to apply them in your own situation and see the cost and how it is effective to the patient. If it is effective, then adopt it. If it is not, then keep it aside, go your own way. That is my last suggestion. Thank you very much. Lovely discussion, lovely I have recapitulated everything today. It's a great day for me. I promise Deepak that I will be there because I need to recap everything. Thank you very
Thank you,
much.
sir. Thank you. On the behalf of whole AIVS-ARC team, I would like to extend my heartfelt thanks to all our distinguished speakers for their excellent presentation today. And the knowledge shared today was truly valuable. I think it's lot when the Basak sir said it's reminder for them, then we all can feel what is the meaning of that word. And sir, a big thank you to our chairperson, Darak sir, Bhupesh sir, and especially to Basak sir. Sir, your presence gave life to this webinar.
Thank
And
you.
I only say that whatever you committed to us or whatever your commitment and dedicated, really we still learn a lot. Just seeing your experiences or the things you said to us, it's just like a summary of book means we can have in our permanent mind. And our another chairperson, Amrita ma'am, is not here. She is in US. She sent us for the World Cornea Congress. She sent blessings to us. And at the last but not least, I would like to thank my co-moderator, Dr. Aditi, and the technical team, Sunil, for giving support, not only technical, but ensuring that we ran the whole webinar smoothly and finished it on time. It's exactly started at 7 and it's just 9 o'clock, not even 9:01, and we finished each and everything. With this, again, I would thank each and everyone for you. Thank you, sir. Thank you, all the speakers. Thank you, Aditya Bhai, for summarizing lovely things.
Thank you so
Thank you.
much.
Thank you.
Thank you.
Good night, everyone.
Good night.
Good night.
Good night.
Thanks a
Good
lot.
night.
Thank you.
Thank you.
Thank you.
Good night. Good night, everyone.
Thank you. Good
Thank
night.
you.